Thank you for a generous introduction. I want to thank Alan, Dr. Holt, and the organizing committee of TOC-ICO to have me come here and present to you such a knowledgeable TOC experts. I am no expert. I made my presentation to show the dilemmas, the struggle that I went through. If I had the TOC tools early on, I probably would have gotten a lot quicker to the results that we wanted to achieve. And after Christina's presentation, whom I heard in TOC for education, I'm very humbled. And there are a lot of dilemmas that in healthcare we go through, and I think you've been a great inspiration for us to continue our struggle in healthcare. The way I presented it is that the first viable vision, which we discovered, the term viable vision after a long time, that we achieved the first viable vision with other tools, not necessarily just the TOC. During my executive MBA at the University of Tennessee, they asked us to read GOAL, the critical chain, and some of the lean thinking, Six Sigma books, balanced scorecard, and we were asked to make a business plan for our practices. I used to be a part of a big hospital teaching institution, a department where we had 1,200 square feet for our department. And immediately I came up with a business plan where we have to do things differently. We couldn't do within the hospital structure. Well, after listening to Christina and some of the other, Julie Wright, I don't know if she's here yet, that I think I gave up too quickly because I didn't have the thinking process tools. If I had those tools, I would have resolved those conflicts up front. So the way the hospital was structured, the space was a constraint because I just picked up one thing, that there's such a thing called constraint. And we made doctor as a constraint. It said if the doctor is constrained, we can maximize the throughput of the doctor's time, we could definitely do better. Because the department was losing money, so we said we got to do better. And we looked at the procedures we are forced to do. We are basically trained to do trauma as a maxillofacial surgeon. In that practice, actually, the department was losing money because most of the trauma patients are indigent patients, they're alcohol-related accidents, the bar fights. The department would never get paid. And there were some other services which the insurance company had clamped down on the hospitals with the reimbursement crunch there. So we said, oh, we got to separate. The constraint is the doctors, let's go buy two facilities, and we expanded from 1,200 square feet to 8,000 square feet. We eliminated the space constraint. In fact, it increased the overhead expense. We made such an investment, we were losing money. Then we hired more doctors. I said, doctors are constrained. Why don't we hire more doctors? Well, the interpersonal dynamics started, and that even made it worse. So we lost more money there. But we were just intuitively said, you know, we need more staff members. The staff are hard to find. The nurses are in short supply. What if we lose a little more money and train the staff and bring more people in there? And oh, wow. Just the light bulb went up. We started become profitable. We also started looking at the patient pool and started dissecting the patient data and say where the patients are coming from. And that helped to see which are the non-profitable services. And that actually created a lot of conflict among the doctors because they wanted to treat the patients. They took an oath. They wanted to treat every patient. And now all of a sudden, you're saying you're going to only treat the profitable patients. Another conflict came is that they were trained in trauma services. Those excite them because there are complicated cases and they feel good about themselves. And now I'm telling them that you are not making any money, so you're my constraint unit time. Don't waste on that. Do something rote and routine. Well, I was searching for answers. I enrolled in a lean program after my MBA, and I said, that sounds good because I did a paper using TOC and lean during my operations research paper, and they invited me with Boeing and a few other companies who were going through lean implementation program. So I spent a whole year. So I did value-added, non-value-added, 5S, standard workflow, all the tools, setup reduction. They did help somewhat. But basically what they were doing is improving, we were subordinating or exploiting the constraint more than anything else, but we actually never improved the doctor touch time. In fact, we also take away a lot of the buffer capacity among the staff, because I was so zeroed in that we got to lean up the processes, we got to take away the people. And that was a cost mentality kept going throughout the whole thing. We even did a demand and capacity management, which was, again, increases your cost, but we were so cost conscious we never really got to implement everything. This is our process. We were able to actually go up to 56% of the ratio of the touch time to the total lead time. Then we also use some of the queuing principles, and we say, okay, we could do some processes concurrently, we can make things happen, but we'll never succeeded in eliminating all the variations. We included our partners, our referring doctors, the suppliers, and say we can lean up the whole supply chain, or the value chain, I called it. Then I struggled in 2003. I took some MIT online system dynamics courses. They really helped, actually. They helped, but it was a very long process. It highlighted that the work, if you overstress your workforce, you're going to get bad dynamics. They would be making more errors, your quality of the work will go, then it'll feed back into your referral base, and the referral base will feed back into your profitability of the practice. But it took so long because every cause and effect diagram had to be quantified. And by the time you made these 6 months long, the diagrams, the reality changed. So we had to make sure that the model fits the reality. It never fitted. So we kept doing all kinds of analysis to figure it out. Well, I said Six Sigma. My wife has to be credited for that. She worked for GE for 18 years. She kept saying that she went through Six Sigma revolution. Dr. Holt wants to. She's actually the brain behind the whole thing. She says, you doctors don't think properly. So you got to give you an engineer's brain. I went through a black belt, master black belt, design of experiments, and played around. Yes, it helped in collections process. We did improvements bit by bit here and there. Customer satisfaction, I got good at making nice run charts and the pictures. Well, we also helped in reduction in the errors, anesthesia errors, failure mode, effect analysis. The DMAG, they're good tools. They really were helpful. We created a culture in the organization that every staff member now is actually better than me in analyzing the run charts and Pareto analysis and zooming in on where the problems are. We also use the 5Y tools and other tools. So we got into design for Six Sigma tools, which I actually used to design the treatment design for each patient as a project. And every patient has a different needs, and based on that, I use axiomatic design tool and then announced it to the whole network of people and the suppliers that can provide us the tools and the equipment for that. So we also use some of the design of experiment on what's working, what's not working. Well, all these kind of things, it did show us when I was taking Dr. Holt's class, and let me look at retrospectively. And we looked at from 2001, we were making only $100,000 profit. 2006, we were over $2 million, and our collection was $2 million. After paying all the doctors, the company was able to generate all that much profit. So we achieved our first viable vision with all the smattering of different tools. So this is just the data, just for the press of time. Actually, we look back and see what are the key success factors. If I were to put on one key factor was a culture development. The culture got used to the change process. They got used to that everybody has to account for something. It became very transparent. And the staff. The staff was the key. We have now about 9 or 10 staff members per doctor. That has made it possible because there are a lot of variations. They are mostly women, and they have children, a lot of them single parents. They sometimes don't show up to work. In my past history, I learned from my wife's the newsletter, Jack Welch, that 20% of the workforce every quarter, you got to cut them. That's the only way you can improve it. That was my biggest mistake. So once we stop firing people, the stability in the practice, we don't lay off anyone now, and it has created a significant stability, and the staff can actually go to the doctor. Most of the errors are coming from you, doctor, because they show on the Pareto analysis, say this is where the variations are. So now our journey starts going into the second viable vision, thanks to Dr. Holt. We were able to resolve some of the conflicts in the goals and in our policies. Again, looking at the culture, looking at the staff availability, how we're going to resolve that, and some of the medical legal issues. But basically, we are very cost conscious. If I put down the core conflict, we did the three clouds and figure out that most of our conflicts are coming from the conflict between the throughput and our cost accounting mentality. We simplified the whole accounting system. We got on the constraint accounting. It really helped us, the decision making. I educated most of my partners in the practice, including staff members. We also looked at some of the procedures. We thought we were making a lot of money. Basically, we were actually not making compared to when we ran the P and Q diagrams in the class. We did this example. And we were able to look at the procedures that we thought were unprofitable, actually generated $1,600 an hour when you look at the constrained unit time. Because people look at the overall fee structure and they say, oh my God, I make $10,000 for this cosmetic surgery. But by the time you add up the time that they utilized, it was really, they were wasting a lot of resources. Well, we stole Dr. Goldrad's, this thing, actually it's in the public domain. I got the permission from Washington State that I think it makes sense to implement using a more logical approach. So we started with our second viable vision, and it did make sense because we already had the strength in our organization with Six Sigma, lean processes, and somewhat of a TOC culture that we can develop more reliability in our systems. Reliability in service, the wait time is the biggest problem in the industry. If you look at why should you all be involved in healthcare is, number one, that we attended a Harvard a curriculum on quality in healthcare. They said 2 jumbo jet filled with people, about 700 plus people die daily because of medical errors in this country. This is the United States, one of the best systems in the world. And these are the ones that are accounted in the Department of Health. Then there's a big opportunity out there. There's a shortage of nursing staff. When we were making a model with Dr. Holt, he said, everybody wants to cut down people. We teach lean health at University of Tennessee with my wife and the university faculty. Everyone comes to the table and say, let's put lean because we're going to cut staff members. Because we are losing money, the first thing is cut staff. That is the culture right now. So this really helped us say, if we want to have reliable systems, we need to work on the things that we have learned. And I put rapid response and listening to the project development. I think some of the things we'll have to modify based on that. But when we looked at the viable vision, said, okay, we want to realize another viable vision in 4 years. The main thing is, of course, we're looking at avoiding the high-risk trauma patients, and that hit right into our conflicts, because when we say we're going to eliminate, the doctors want to do those things. So we said, why don't we just balance it out? There's no conflict in reality. We could do some 60-70% of our time can be put into doing profitable services and then charitable services. We divided into 2 and sat down with our doctors to resolve these conflicts. I'm not going to go into details, but basically the shortage of trained staff, trained doctors, that can be resolved by giving them better service. If your company is making money and be profitable, you could attract better people into your services. And if your culture is like, they're not firing me on a daily basis, on a weekly, monthly basis, they're going to come and work for you. We went through the next level here. Basically, we're looking at wait time. Wait time, not just the wait time, if too many people are in the system, there are too many in queue, actually they are occupying capacity. My partners kept saying, oh, we got to bring another doctor. We have to build another facility for $1 million. We looked at it when we did the job shop game with them, and we said, listen, if we choke the release a little bit, we'll be able to open up half the capacity. And they now look at it as a half of my office is just sitting there, the facility's there, but it's open. Because they didn't have to put in 7, 8 rooms, all these patients lined up. You're bringing them slowly, you're choking the release in there. So those are the things we learned, plus we gave the money back to account for it. We actually, if a patient came in for consultation and waited more than 15, 20 minutes beyond their threshold, we had gift cards. That gave us an accountability that we were able to Pareto the reasons why were we delayed, and we can help them out. So how many cards we issued every weekly basis. And the weekly data is available to all of us. We put the simplified drum buffer rope, we don't use any software, but we have the management, regular practice management software. We looked at the lead time and said we're going to reduce the lead time, because if the patient is waiting even after the doctor to check out, to reconcile the accounts and all those, they also occupy the resources and places or the rooms where they have to be eliminated. So we figured out that some of the things can be done parallel, some of the kitting part, that everything is organized before the patient even comes into the practice. Right now we're working with the Realization Company to work with their Concerta. We already have it. We're playing with it to see how we can use critical chain project management tool to implement it. And I could tell from preliminary, because that has been our biggest problem, even implementing process improvements and holding events and having a relationship building with our clients and referring doctors. All those are projects. And the same resources that we use to do surgery are working on those events and the planning. So critical chain will be very useful in our world, and I'll give you a report by next year. Buffer management is very helpful because it zeroes in on where we really have to focus. Again, I covered the choking the release. I don't want to waste too much of your time. You can read it. In healthcare, there are a lot of random arrivalness, a lot of variations. Every patient is different. Every patient has different needs. Some talk a lot. There's a lot of absenteeism in the workforce because of their personal reasons. Their treatment needs are different. We were not able to, even though we said doctor is a constraint, we weren't able to keep the doctor as the only constraint. That's why we use a simplified drum buffer rope to see, as the patient is completed, the total lead time. So dealing with some of the lean tools were extremely useful in focusing on the doctor resources. All our setup reduction, we don't occupy the operating area with the tools, and it's not done sequentially. I give you an example. Same procedures if I do in my office, outpatient surgery center. If I do 2 or 3 patients, I could do it in less than 2 hours. If I go to the hospital, it's a 6, 7 hours delay because the culture is not there. The nurse, the head nurse, is not going to pick up the brooms and clean the room or sterilize the turnaround time. The setup is done very late. We were teaching Montreal Children's Hospital. CEO there came to our lean program in Tennessee. She says the wait time for tonsillectomy in Montreal is 18 months because their utilization, OR utilization is less than 50%. But the nurses, they have this mentality, if they did one big case, the 3 hours are left now, we can't bring another case because they'll run into overtime, we can't pay the overtime. So there are a lot of cultural issues that can be resolved. And just to give you an example that the viable vision, second viable vision, we started out, I finished Dr. Holt's first 534 course in May of this year. We were implementing and playing again. We are experimenting, as Dr. Goldratt mentioned, as a prototype. We always are experimenting it. We were able to increase our collections by $750,000 just without increase in any staff member or increase in a doctor. And doctors work 1 day less. So that I didn't add. Some of the conflict resolution, I'm educating my staff. Now everybody is going through, like Christina's, that gave me a lot of inspiration. I went back and now every Tuesday morning at 1 hour, 2 hours, they get a dose of TOC, how to make the diagrams and cause and effect diagrams. We still have problems. If I were to extend it to a bigger healthcare system, there are cultural issues, there are specialization. I just do this part, and there's a lot of multitasking going on, so I put some of the solutions that TOC can offer us. Same thing in the staffing, I think I covered that. Medical legal, we could use some of the tools that we learned in other areas like Six Sigma and Lean. Now the question, this is up to you guys. I mean, can it be applied? Yes, my wife now has left GE and she does consulting. She had terrible rheumatoid arthritis, she couldn't travel too much. So we got a few other companies that she's working with, healthcare, and she shows results every time, but the change in the mental process, the mental models, is the hardest part. And that we never recognize. We did operations. My best subjects were operations and finance in my MBA. And like Ravi pointed out last night, we had dinner with him. He's from India, Goldratt. He said the MBA stands in Indian Maha Bevkuf Admi, which means the most idiotic person. And I know why. And I understand why, because you get conflicted. I was brainwashed in activity-based costing. I'm doing a project with this teacher. Then I'm doing lean systems. I'm doing a Six Sigma. You go back and forth, back and forth. There was no concentrated. System dynamics did give you a cohesive tool, but it was too difficult for anyone to learn, which the thinking process and other DOC tools are very easy to adapt. Same, again, I think I just put down my thoughts on it. You start with the top management. If I look back, the mistakes I made, got to get a buy-in from the top, otherwise it will never work. You get the measurements that conflict out of the way, make sure they're not cost-oriented. Then you resolve, you have your global system thinking processes, and of course use Six Sigma, Lean, and patients and referring doctors on a customer on one end, and people, your staff is the key in developing a culture. And thank you for listening.